So good afternoon. It's my pleasure to welcome you to today's webinar, an outlook on 2021, a COVID-19 update. As you know, we are committed to keeping our alumni and our friends engaged with Saint Anselm, and by partnering with our centers, institutes, other departments on campus, and our alumni, we continue to offer webinars, podcasts, and other opportunities to help you stay connected. I personally think the variety of programs that we've been able to offer in the last 8 months have been quite impressive. And it's thanks to many people who have offered their expertise or suggested a topic. I would encourage you to contact the Alumni Relations Office if you have an idea for future programs. We're always open to that and ways to continue to engage our friends and alums around the world. Today's webinar is being recorded and will be posted on the college's website for those who can't make it live today. Our panel will speak for about 25 minutes or so, and then we will just open it up for questions. There's a Q&A button on your screen to submit questions, so feel free to do that as we go through the presentation today. It's my pleasure to introduce our panelists, our distinguished alums who are here with us today. First, Ashley Conley is a member of the class of 2006 and then received her Master of Science in Infectious Diseases and Microbiology from the University of Pittsburgh. Ashley is currently the Director of Infection Prevention at Catholic Medical Center here in Manchester, where she leads a team of infection preventionists to prevent healthcare-associated infections and enhance patient safety. Her current focus is the response to the COVID-19 pandemic. Ashley is also the current president for the New Hampshire Infection Prevention and Epidemiology Professionals. Next up, we have Dr. Mark LaForce, who received his BA from Saint Anselm College in 1960 and earned his Doctor of Medicine degree from Seton Hall College of Medicine and Dentistry. He currently holds the rank of Clinical Professor of NYU's Langone School of Medicine in New York City. Over the last decade, he has worked on the development of new meningococcal and streptococcal vaccines for resource-poor countries and currently serves as Director, Technical Services for the Serum Institute of India. And finally, Jeff Sanders received his BA in Politics from Saint Anselm in 1992 and a master's degree in healthcare administration from the University of North Carolina, Chapel Hill. Jeff has been president of Maine Medical Center in Portland since 2018. Prior to that, he served as executive vice president and chief operating officer responsible for the day-to-day operations of the hospital. And before joining Maine Medical Center, Jeff was the operating officer at Intermountain Medical Center in Murray, Utah, where he oversaw cardiovascular services, imaging services, sleep services, hyperbaric medicine, surgical services, transplant services, and medical research. Thank you so much for taking the time out of your busy schedules to participate with us today. Once an Anselmian, always an Anselmian. As some of you may recall, you heard Dr. LaForce this past spring regarding COVID as COVID was making its way across the US and at the very start of the pandemic. Since then, COVID has certainly posed challenges to us here on the Hilltop, but through vigilant planning and execution and hard work, we have just recently wrapped up a successful first semester. I'm so grateful to our students, faculty, and staff who have made this accomplishment possible. Just to give you a couple of quick facts, since August, over 10,000 rapid antigen tests were performed on campus, resulting in a total of 53 positive cases and 208 students in quarantine over the course of the semester. We also adopted the Anselmian Community Care Covenant, which addressed our commitment to supporting one another and the need for ongoing grace, compassion, and care. In today's discussion, our panel will address the science of this pandemic as well as the human element that many of us can relate to. So let's just jump right in, and I think I'm going to start with Dr. Mark LaForce. Mark, do you want to give us a sense of where we are at this point?
Will do. Could I have the first slide, please? I'm the bearer of bad news. The slide's entitled Unsettling Times, and that COVID has the upper hand, and frankly, nothing could be truer right now. We have the really difficult task of trying to deal with an epidemic that in the springtime we felt that we had some options, but that in point of fact, things have gotten worse. Next slide, please. This is seen here in the most recent data. I took these down December 1st. The only difference between December 1st and today was that yesterday we set a record for number of COVID deaths, reaching, I believe it was over 3,000. But we've got 14 million cases, now approximately 275,000 deaths, and a country that frankly is reeling. Next slide. Perhaps a good way of, or an appropriate way of looking at this is just look at the number of active cases in the United States. And the numbers are staggering because that's where all the new cases will unfold from these particular active cases. And the curve is dramatic and it's moving obviously in the wrong direction. Next slide. We ask ourselves, and we asked this question in the springtime in terms of what could change the epidemiologic picture. And at that time, we didn't have pretty good information on whether there was going to be a new therapeutic agent, something like penicillin and pneumococcal infections that could effectively treat this particular infection. Well, it's clear that the likelihood is low. All of the advances in terms of chemotherapeutics have been what I call marginal advances. So that's not going to help us in the either long term, and it may help in individual cases, but will probably not have any public health impact. We discussed a bit also vaccines and the introduction of these vaccines at public health scale. Here the news is much better. The likelihood is high, and that new vaccines will be introduced by the end of this year, that is in December. But I would caution you that public health impact is going to take time. The denominator, that is the number of individuals that need these particular vaccines, is huge. And there's likely to be a lot of elbowing as the vaccine gets distributed. Could I have the next slide, please? The reason why this particular, or these vaccines are so important has to do with how this organism circulates. You could see that this is the coronavirus, this little ball with all of these little buds that are sticking out, and it usually just circulates and is acquired by individuals who are obviously susceptible, and then some develop severe disease, and younger individuals, as a rule, end up being major spreaders because a sizable fraction of them are asymptomatic. However, if individuals receive a vaccine, could you press the next switch on the slides, please? Yeah, there's a piece of magic that happens with the genesis of protective antibodies. This cycle of spread amongst peoples that are exemplified in this cartoon just comes to a stop, such that if enough individuals receive vaccine that's efficacious, the transmission basically ceases within 2 transmission cycles. So the possibilities for a significant change are big as long as individuals are immunized. Next slide, please. What to do in the meantime? Here, it really is key. I talk with people that are in the health system in terms of nurses, physicians, and not only just nurses and physicians, but it's people who take care of making sure that hospitals are clean, that physicians' offices are clean, et cetera. There's a whole workforce that makes sure that this is safe for individuals. These people are exhausted. And we really need to make a major effort at flattening the curve so that we decrease the stress on the medical infrastructure over the next 6 to 9 months. And could I have the last slide? I think it is. What we're left with, uncertainty, fear for sure. What is it that we know? We know that distancing, wearing masks, and stay at home all work, but that when we do significant lockdowns, there are economic costs. And how do we manage these uncertainties? In the short term, I think we need to listen to Tony Fauci, CDC, Dr. Redfield, and follow their recommendations to use masks and distance. And we must work to flatten the curve in order to ameliorate the stress on health providers and first responders. The second issue is something that is just beginning. These are the COVID-19 vaccine distribution plans. The first set of documents have been distributed from the Advisory Committee on Immunization Practices at the CDC. We need to pay attention to those. These are serious people who have made these recommendations, and we need to follow them. The recommendations, as I've seen, certainly for the state of New Hampshire and the first draft of the ACIP, do respect this issue of egalitarianism, and it's a question of how this can be operationalized so that it works smoothly. So with these, again, uncertainties and difficulties that we're going to have to face, I'll close my comments. Thank you.
Thank you, Mark, for those sobering statistics and those remarks. I'd like to ask Jeff Sanders, as the president of Maine's largest medical center, how's your hospital handling this incredible surge in cases that we're experiencing at the present moment?
Yeah, thank you. And Mark, thanks for that sobering but very factual update on where we are. You know, last night at this time, I was sitting with our board going through a very similar conversation and really bringing it down to how does it impact Maine Medical Center and our broader greater Portland community. Let me just start by talking about what's different from this surge. And to me, it's not night and day, but it's morning and afternoon. We are not spring going into summer, we're fall going into winter, which I think raises the concern that Mark highlighted for us. Let me just share some things that I think are different here at Maine Medical Center, probably very similar for Ashley at Catholic Medical Center. We're prepared. You know, we learned a lot last time. We shut things down very quickly, and we learned how to care for these patients, how to separate the care for COVID patients or those being evaluated from patients who are here for non-COVID care. We have the right PPE for our staff. We're confident we can manage throughout the pandemic with that for our staff and our patients. The staff are much more comfortable caring for these patients at this point than they were last spring. We have a good surge plan that we will use to dial back services. And when you put it on paper, it looks very elegant. In reality, it's a little bit messy. And that's what we're going through right now. Let me give you some examples. One thing I would share that also makes it different, here in Maine, and I know it was true in New Hampshire and Vermont as well, the prevalence of the virus early on was very low. Even as we had sufficient testing, the prevalence was 0.4% here in Maine through the fall. Right now, it's 5%. Many more people walking around with the virus, many more of our colleagues coming down with the virus in the community. We were talking earlier about what's going on at Elliott Hospital. All hospitals are seeing that. It's not uncommon for Maine Medical Center on any given day, we have 8,000 employees, to have north of 200 employees who can't come into work. Either they have the virus or they're being evaluated for the virus. That creates staffing holes for care at Maine Medical Center. The other thing different, we're not immediately stopping elective services. That has consequences when we make those decisions for access to care in our community. It has other consequences for the viability of our healthcare organizations as well. Today at Maine Medical Center, we have roughly 60 patients in beds, either positive for the virus or being evaluated for the virus. That's more than we had in the spring. We've already exceeded our numbers that we saw in March. Maine Medical Center has cared for more than half of the patients hospitalized for the virus in the state. We anticipate seeing those numbers go up significantly. We're tracking that. I will not be surprised if by the end of December, we have 100 patients in the hospital being cared for, either positive for the virus or being evaluated for the virus. That'll put significant stress on our ability to care for patients who would be here for non-COVID care. I was sharing just before we came on the panel discussion, starting Monday, we will reduce our elective surgery schedule at Maine Medical Center for patients who otherwise would need a bed for care that could be delayed for 3 months, reducing our surgery schedule here on this campus by about 18%, which is very significant for our community. Starting tomorrow, we will eliminate visitors from our campus, going back to where we were last spring. I don't think I need to tell anybody the impact that has on the recovery of patients. It is so important to have families involved in the care, but given the amount of community transmission we have right now, we can't take the risk to exposing our staff to any further risk. Let me share a couple of concerns that I see as we continue. The first one, of course, is staff safety. The most important resource for us to protect in healthcare right now are the doctors, the nurses, the housekeepers, those providing care to our patients. If we cannot protect those colleagues, we will not be able to provide the care we need to provide either to patients with COVID or non-COVID care. Strongly related to that is staff fatigue. I am really very concerned about the fatigue of our staff right now. And I know we're all fatigued in our communities doing things we otherwise wouldn't do. Thanksgiving was different for all of us. Christmas will be different. But you have to picture the staff walking around Maine Medical Center. I'm sitting in my office by myself, so I don't have a mask on. Every day, our nurses are wearing a mask and they're wearing goggles. And when they forget to do that, goggles in particular, they put themselves at increased risk for virus transmission. That has happened here. It's happened probably every single hospital in the United States. Last thing I'd say, and I'd turn it back, is managing the balance of care for our community. Maine Medical Center is the only level 1 trauma center, the only level 4 NICU in our state. If we can't provide those services to our state does not have the access to that care and they have to go to Boston. Earlier this week, of 28 hours over the course of 2 days, 24 of those hours, we were on trauma diversion because of patients being backed up in the emergency department because we had to close units because of outbreaks related to COVID. That's not unique at Maine Medical Center, but it provides an incredible concern for the access to care for our community. So I just go back to Mark's comments and I'll close. We have to do better as a community of taking the precautions that Dr. Fauci and others talk about to flatten the curve of this virus. It does not eliminate, as Mark pointed out, the number of people who will get the virus, but it spreads it out so we do not stress our healthcare system any more than we are right now. Thanks.
Wow, thank you, Mark. I'm sorry, thank you, Jeff. Again, a pretty sobering assessment of where Maine Medical Center is and the steps you're taking. Before I ask Ashley to comment about challenges she's seen right here in New Hampshire at the Catholic Medical Center, again, just to remind you that you can submit questions on the Q&A function at the bottom of your screen. I invite you to do so whenever you can. So Ashley, what are you seeing here in Manchester at Catholic Medical Center, and how are you trying to keep your staff healthy and safe?
Yeah, and listening to Jeff, everything's ringing true to here in New Hampshire as well. And if I can, I just want to take you all into the weeds for just a minute. In my job in infection prevention, we're at the front lines of trying to keep the virus from spreading from a patient to a staff member, from a staff member to a patient, from a patient to a patient, and from a staff member to a staff member. So if you think about each one of those encounters, there's opportunities for any one of them to come back positive for COVID-19 and then have the potential to be able to expose that to others within their circles. So when Jeff was mentioning all the things that we're doing, it's to prevent and stop the transmission and stop the spread of that infection through all those interactions. So many of the policies and things that we have in place is to stop the transmission. And that is definitely something that takes a lot of energies. And if Megan, you could pull up my my slide for a second. I apologize, this is going to be a very busy slide. And I did that on purpose because it highlights the many challenges that we are all experiencing. And when you put it all in a slide, it really is shocking. I sit on the incident command center here at the hospital, and each one of these bubbles represents challenges that we've had to either overcome, and some of them we have. Some of them we've overcome in the spring and we're better prepared. Some of them we have to overcome on a daily basis. And the fatigue that both Mark and Jeff have mentioned is very real. So I just want to pick out a couple of these. Back in the spring, our PPE shortages was at the forefront. We had lots of fear from staff. We weren't sure when our next shipments were coming in. And that we've seemed to overcome. You know, I think many of us have some good stock and we feel we're good. But then what happens now is we've been wearing this PPE for 9-10 months, and that gets really tiring. If you wear a respirator, eye protection, gown and gloves for a whole 8 or 12-hour shift, just imagine doing that multiple days in a row, how that wears on all of us. When you think about the visitor restrictions, we did that back in the spring. And then about 3 weeks or so, we did that again here at CMC. And if you dive into just that one by itself, imagine all of our patients here not being able to have their visitors, and then the communication challenges. So being able to communicate with family from the providers and the nurses, that patient being able to communicate with their families. And although we overcame a lot of challenges with that, and we have some great technology to do that, it will never replace that person sitting there with you. So our staff have the PPE they're wearing. They're having the communication challenges with visitors that are not allowed to be there. We have changing guidelines. So every week, there's different guidelines that are changing, that we're updating, being able to help staff understand those changes and understand, be comfortable with them is challenging. And then they're also hearing things like, COVID-19 is no worse than the flu and things of that nature. Whereas here at CMC, for the numbers, we've had 293 patients hospitalized here since the spring with COVID-19, and we've had over 50 deaths just here at CMC. And when you think about the stress and impact that's had on our staff, it's immense. And while it's true that as more people get COVID-19, we build that immunity, it's also true that there's a lot of harm coming from that. So if you notice one of these bubbles on here, the COVID-19 long haulers, and you probably heard those terms, they've had post-COVID fatigue, there's a variety of different terms for it, but it is a real thing. And it's also affecting those in their 20s to 40s as well, that maybe only had a mild illness. And those patients are starting to see, longer term issues with shortness of breath, heart palpitations, brain fog, those sorts of things. And that's a real thing that we're seeing. And that's a whole other aspect that now healthcare systems are dealing with. How do we care for these patients? What can we do to help these patients? So yes, the more people that get COVID, it does help build that immunity, but at what cost to that person, and what cost with the number of deaths? That's one thing that has really hit our staff hard. Thankfully here, we've had about 50. That's not what hospitals, say in New York City and other areas of the country have seen. They've seen double, triple, quadruple those numbers. And you think about the impact. Healthcare workers are here to save people, right? They're there to help people. They want people to get better. And when you're constantly up against pulling those, intubations out and helping people at the end of death, that's a lot for them to take on. Then you're looking at coworkers that develop COVID-19. And when you have a department and one of your coworkers all of a sudden is diagnosed with that, you start thinking to yourself, oh, did I eat lunch with them? Was I within 6 feet with them? Was I always wearing my mask? So when you just think about the anxiety level throughout the hospital, it just increases with more staff coming down with COVID, across the system. And then we're also dealing with testing challenges. We have testing up the wazoo at both our urgent care, our offsite testing clinic here within the hospital. So if you think about the impact to our lab system, being able to handle that, and as well as with the community, the community needs for testing is great. So there's a lot of different stressors that we're just working through trying to overcome. And that's not including our personal stressors in life, right? So healthcare workers have families, they have kids that maybe are in remote learning, or their childcare center has been shut down, or they have an ill family member or parent that they're either worried about or trying to care for. So when you think about challenges, all these on the slide don't even include what people are just dealing with in their personal life. So I think what you're seeing after 10 months is exhaustion, as I think Mark and Scott, Jeff just mentioned. How do we keep going and knowing that this is not going to end in the next month? We have quite a few months ahead of us that we're going to have to just keep chugging along to overcome the challenges.
Thank you, Ashley. I mean, again, kind of a very sobering picture of where we are. And I would say that, everything that certainly I'm reading and others are reading is that the next 3 months particularly could be quite challenging for us, and how important it is to continue to take all of the precautions that we've been taking. I'm going to go back to Mark for a moment. I think the question that so many are curious about, and in some ways curious because it represents light at the end of the tunnel. In your experience, how will the potential vaccines for COVID compare with vaccines that we've had in the past? So, for example, we all take the flu vaccine, but we know that we could still get flu, and so how does it compare? And then, what are your thoughts about why were we able to fast track it like we have? It's apparently so. Any thoughts about that, Mark?
Yes, sure. Interesting questions. Number one, let me start with the fast tracking, because I think that's a very interesting story and it bodes well for what may happen in the future. Remember that the Chinese sent out the entire genome of this particular pathogen back in January of this year. With a genome, individuals who know how to work with this now no longer have to wait for the viruses to end up being shipped across continents and then going through customs, doing all of this stuff. And so scientists were able to work immediately with the entire genome. Were able to quickly recognize that part of the genome that codes for these buds that are on this particular virus. And they were able, because of prior research activities, to insert this genetic material into part of our genetic system that involves what's called a messenger RNA. And their ability to do that literally jump-started what in the old days would have taken at least 2 years, frankly, in terms of development work. So I think that we are net beneficiaries of all of this investment that's been done for HIV vaccines, for all of this work that was done in the past, because they've been able to use these techniques to really jumpstart this entire process. Okay, step one was jumpstarting the actual vaccine development. Number two, which is just as demanding, is the regulatory process. And the regulatory process for new vaccines is often what we call in series. You have to go through one step and you have to get this approved before you go to the next step and next step. And I guarantee you, it is extraordinarily demanding And what they were able to do this time, because of the rush and the pandemic itself, is they were able to do a lot of parallel work so that items that did not necessarily need to be in series were set up in parallel. And we're seeing right now the huge benefits that have occurred as a result of that. Third is the importance of being able to do what's called an efficacy trial in the midst of an epidemic. Oftentimes, you develop a vaccine and you develop all the infrastructure to do a particular test. And the disease, if you're working with cholera, plague, or some other pathogen, all of a sudden takes a break. And so you end up trying to prove nothing because there's no disease. In this particular pandemic, that was not a problem. They were able to take particular products and put them into people and rapidly assess whether these vaccines were efficacious or not. Okay, one word about efficacy. These vaccines appear to be extremely effective. We're talking about initial rates of protection, that is vaccine effectiveness in the plus 90% range. Now, flu virus or flu vaccines, if you have a good year, are at best in the 50 to 60% range. And so for whatever reason, these vaccines appear to be extremely effective. And that is a huge step forward in terms of facilitating next steps. So I think that would be the briefest way in terms of hopefully describing why this happened so quickly. To you.
Thanks, Mark. And Ashley or Jeff, any thoughts about, as the vaccine gets approved, as we assume it will be, thoughts about the distribution timeline, and what are you seeing or hearing about frontline workers, those who are in the hospital, high-risk patients receiving the vaccine, and how quickly? Maybe Jeff, you could start, and then Ashley.
Yeah. So we anticipate receiving vaccine this month. Initially, the plan was that we would receive around 36,000 doses from the Pfizer vaccine, assuming it's approved by the FDA. We've received word that that's down to about 12,000 doses. So the distribution will be slower than we initially thought. And we're following, the guidance from the CDC. We will be vaccinating frontline workers first, and we'll be, prioritizing those who are in areas like the ED, critical care, caring for COVID patients, and then move out from there. So we're hoping to have vaccine, shortly, and hopefully the supply chain picks up so we have more doses and we can do it more quickly.
Is very similar here in New Hampshire, where we're expecting doses within the next couple of weeks. So the big push right now is to make sure we know when we're going to have our vaccination clinics, where we're going to do it, how are we going to prioritize within that group, as Jeff mentioned, and just be ready to have that. The vaccines, again, with that cold storage, they have to be, really cold storage. When they thaw it, it has to be used within a certain amount of time. So that's just some added complexities around making sure your vaccine clinics are timed correctly. You have people in the system. So that'll just be different than what we probably had to deal with other vaccines in the past.
Thank you. Thanks, Jeff and Ashley. Well, we're going to go and pick up a few questions that have been submitted. The first one is, says, while it's true that active cases are increasing throughout the U.S., isn't it also true that better than 95% of those who contract the virus recover from it? And then aren't they immune to it? I don't know, Dr. LaForce, do you want to take that one?
Okay.
You're on mute, Dr. Mark.
Okay.
There you
The
go.
answer to the question is yes. Fortunately, not everybody develops a severe pneumonic syndrome as a result of this contacting this particular virus. However, 5% is huge. This is not a trivial number. It means if you have 1,000 people, that's 50 people that are going to be in some difficulty. So my answer would be that 95%. I'm not sure that number is or how reliable that number is, but if it is, that 5% represents a huge disease burden for the population itself. What was the second issue?
It was about once they recover, will they not get it again?
Yeah. Thank you. We haven't studied enough of these individuals, but the individuals that have recovered have all generated ample antibody titers. And I fully expect that individuals who are infected will be protected naturally as a result of their immune defense mechanisms. How long that protection lasts is the question that remains to be answered, and won't be answered until another year goes by and we have a chance to study enough individuals.
And while you're on the screen, Mark, any thoughts about, I know we were just talking right before the webinar about Pfizer's announcement about the issue with supply chain. Supply chain is kind of vulnerable with the vaccines. And what are some of the challenges with the supply chain?
Well, with this, I think we know how to move vaccines around in the United States. As Ashley pointed out before, the tricky one, particularly with the Pfizer product, is the minus 80 degrees and the fact that you have to restructure your immunization sessions to coincide with some of the realities of working with a labile vaccine, and that always causes problems. We would much prefer, frankly, to have a vaccine that's stored at 2 to 8 degrees that you could just take out of the fridge and then use. But we'll learn from this. I don't see this as, frankly, a huge problem in terms of being able to sort of move vaccine around. I think, as Jeff pointed out, the big problem is going to be the amount of vaccine. And that is going to be problematic, I'll bet, until late spring of next year. To you.
Thanks, Mark. Another question has come in to thank all the presenters. Ashley's diagram indicates the personal life stressors faced by people in the healthcare profession. And often our culture thinks that we must leave our personal life at home. So how are hospital administrators, people in positions like Jeff, you and Ashley, how are you dealing with the issue of employees who perhaps have these big personal issues impacting their work? How do you support them when you need them on the front lines? I mean, what's the challenge there? So maybe Ashley, you want to start with that? And
Sure. So our human resources has spent a lot of time trying to help staff, and a couple challenges that we tried to overcome, for example, was childcare. So we actually are affiliated with a childcare center that usually only takes children under 6, but during the springtime especially said, if there are any children of Catholic Medical Center employees that needs childcare, we are happy to take them. So that allowed some of our staff to have access to that childcare that they might not have had otherwise. They've also worked a lot to make remote work an option for staff that don't have to be physically in the office to see patients, which has been a huge help for a lot of parents that have students doing remote at home. And then we also have a lot in place with making sure we have testing. So testing has been one thing that staff feel like if I've had an exposure, or whether it's here in the hospital or in the community, they just want to have access to that test. They want to know what their status is at different points in that incubation period for their mental health and to know that they're keeping their family safe. So doing things like that helps relieve some of that anxiety and worry, and just saying, yes, we are here. We are going to help you through this. And then making sure that our chaplains are out rounding on the units. They're great sources of comfort. So they round, talk with staff, and then making sure we have our employee assistance program and things like that available.
Thank you. Jeff, do you want to comment on that?
Yeah, a lot of very similar things. You know, it's different in the now than it was the spring. In the spring, we actually we provided stipends to our employees to help with childcare, which was used quite generously, which was great. We can't afford to do that this fall. It's a little more challenging this fall because of the school schedules. You know, it was a little different in the spring. It was very predictable, less predictable now. I think the most important thing that we're doing, as Ashley mentioned, is providing social support, whether it's direct services we provide or matching people up with contracts we have with the agencies in the community at this point. But, you know, it's important to point out that it's, you're probably seeing it at the college too. That's probably the biggest stressor, is matching up people's personal lives with the jobs we need to do.
Yeah. Yeah, we definitely have seen it here, and trying to support our employees, our faculty, as they are trying to do the work that we need to do to carry out our mission. Here's a question that is pretty interesting. We see people not wearing masks in spite of overwhelming evidence that they are effective. Is this like the difficulty in getting people to wear seatbelts or to stop smoking, even though there is compelling evidence of the benefits of doing so? Is there a phenomenon in healthcare where populations significantly delay making changes that could dramatically improve outcomes? How can we change this? So any one of you want to tackle that one, or just?
Yeah, I'll comment on that. You know, this is something that has concerned me hugely. We know how to behave in a medical sense. And what's happened is, as we've gone through what has been an extraordinarily difficult political time over the last, I would say, 3 or 4 months, we've ended up, you know, making this pandemic a political statement rather than a medical problem. I must admit, I am so discouraged during doing or listening to some of these interviews of individuals who refuse to wear a mask based on their sense of their personal independence, which completely ignores the fact that they put other individuals, because of that behavior, at increased risk. I don't know how to solve this, Dr. Favazza. You know, and I would hope that ethicists or individuals who are much more clever than I am would look at this, but in a really a depressing sense, I just don't get it. Do you?
You know,
certainly. Oh, go ahead, Jeff.
No, I'm sorry. I was just going to share. You know, I was working out at home, and had a couple of college football games on that I was going between. One was in LA, and one was in Florida. The one in LA had no fans. The one in Florida was probably a quarter full with fans. I mean, geographically, there's significant differences with how I think we're adapting to this virus. And, you know, the mask question, I think, is just one element of it. And, you know, I just point out, probably it's from, whether it's my education at St. A's, wherever, you know, we're one of the liberal democracies that has a Bill of Rights. And I think, we're telling people to do something they otherwise wouldn't normally do. And I think that's a challenge. And I think it's an unfortunate challenge.
Yeah, it's certainly unfortunate that this has been politicized in so many ways, and but you're exactly right. But yeah, I want to go back, and there's a couple of questions, and maybe Ashley, you could take this, and anyone else. Is there any thought of having retired nurses help with the vaccinations, or retired nurses, or even I guess the term is let's see. nurses who might be temporary contractors, AKA travelers, who would be, because, what I'm hearing is that, some people, hospitals may get to the point where you just simply can't staff anymore because of the numbers. I mean, is that something that CMC is considering or doing?
Yeah, so it's a great question. And I think within the health system, we have the capacity to vaccinate our own and probably our own patients. But when you start to talk about the community setting, when they start to have community vaccination clinics, that's where the opportunity will probably come to have more volunteers and people assist, because that's very different than just trying to manage our health system. And I'll just mention there's a couple of volunteer groups. One of them is the Medical Reserve Corps, and I know New Hampshire has a couple medical reserve corps across the state. I know Maine probably does as well. So there are those opportunities to have people join and get more involved, because that will definitely be a need later next year when we start to open those clinics up. As for the travelers, I know hospitals across the country are utilizing travelers to maintain staffing levels. And that's actually something that's been a challenge, because we're all looking for help with staffing, but the travelers we are utilizing here. And that's something else that when they do the community clinics, they'll contract with certain organizations to have them come help as well.
Thank you. This one is about the problem of convincing doubters and anti-vacciners, I guess, to get the vaccine, or hearing stories like, I've heard that the side effects of the vaccine may be similar to the side effects experienced from the shingles vaccine. Any comment on that? How are we going to get people to take the vaccine? Do you have any strategies that you think will work or we need to be thinking about? Because we've certainly heard some folks who said they have some fears about it. Mark,
I would say my argument with how to get individuals to use the vaccine, if you start with a vaccine that's 90 or 95% effective, then you should be able to get out of the way. People are going to want this particular vaccine. They want more freedom. They want this. And my sense is that once this gets rolling, I don't think the anti-vaccine issue is going to be terribly relevant, frankly, in terms of the introduction of this particular vaccine. Hopefully, I'm not wrong with that assumption, but I'd be interested in what others think. Thank you.
Anyone else on that? How to get people to take the vaccine, or?
Yeah, so one of the things we're doing is we're using our academic clinicians to be a voice to explain, as Mark did, the efficacy of the vaccine, and to educate the community about how effective this vaccine appears to be. Just as a story here, we mandated the influenza vaccine for the first time this year for our employees. We will not be mandating this vaccine at this point, given its newness. So it's going to be educating people and demonstrating its effectiveness.
Here's a question, and I guess, Mark, maybe this is to you. The challenges of acquiring and distributing vaccines to developing countries. I know this is something that's near and dear to your heart. Do you see that the vaccine, are we going to see some sort of inequalities in the distribution of vaccine between developed countries and developing countries?
Yeah, I would say that's a fact of life. Developing countries or resource-poor countries, there's no way they can afford $150 a dose for a particular vaccine. And I think that conundrum is going to be answered in terms of the major vaccine suppliers like the Serum Institute of India that are working with AstraZeneca and already have contractual obligations to the government of India, the government of Bangladesh, the government of Malaysia, any number of countries, and that final transfer price for that vaccine would be somewhere in the range of, I believe, $3 a dose. And we don't have the efficacy data on the AstraZeneca product right now, formally. what I've heard is that it's no different than any of the other vaccines. But once that's established, that then sets up a major track for vaccines to resource poor countries. And so I would be, frankly, much more optimistic as a result of these investments with developing country vaccine manufacturers, Joe. To you.
Thanks, Mark. Thanks, Mark. Here's one, and maybe Ashley could take a shot at it. Generally, the public thinks about science as a collection of already known facts, but this pandemic has provided a look at what science really looks like when it is happening kind of on the ground. How easy has it been to pivot as a result of that? I mean, just science happening right before our eyes. Any thoughts about that? I see Mark smiling on that one too.
Yes, I loved this question. I saw it in here and I was hoping, Dr. Favazza, you would actually bring it up because
from one of our faculty members.
Yes, it is so true. And it has been a blessing and a curse at the same time. So it's a blessing because it's definitely helping us, right? Things we didn't know in the spring, we know now. Treatments, the whole gamut, PPE, what works, what doesn't work. So it's been a blessing, but it's also a curse at the same time because sometimes if something changes in the direction that you're not prepared for it to change to, it can be a lot. So for example, there's been a lot of back and forth around N95s. How often can you reuse those? Can we reprocess them and reuse them? How often can you? And there's just been all this literature and none of them are really agreeing. So that's an example of a challenge we have. What do we decide? We have 10 different papers. They're all saying something slightly different. And we have to just put our hats on and say, okay, let's think through this. And then use our best judgment for making decisions. And I know one of the hardest jobs I've had, and probably Jeff as well, is making decisions as a health system and taking into mind, okay, how is this going to affect our patients? How's it going to affect our staff? How is it going to affect our finances? The whole picture. So yes, I loved that question and a great question.
Anyone else want to take a shot at that?
Let me give you a fun example just from 2 days ago at our Hicks meeting. We were having a discussion about the incremental value of wearing goggles versus a face shield, right? And
yes, I have to laugh, Jeff, because it is so true. We've had the same conversations.
And so we're sitting there debating it, and our chair of critical care, who's also a very accomplished researcher, said, "Hey, gang, there's no science here. There's no proven science. What's proven is you wear something. And so if we're not wearing something, we're in trouble. So let's wear something."
It sounds very familiar. And that's what we do, right? In healthcare, we take everything that's out there, we distill it down, and we make the best decision we can. And then we live with it.
So I know we're running, we only got about 5 minutes left. So here's the question that I think a lot of people are asking, and it is the very fundamental question of when do you think things will get back to normal, or will they get back to normal? What are you thinking? And of course, this question is very important to those of us at Saint Anselm because it's related to the question of, will we be able to come back in the spring? I mean, right now our students are scheduled to come back on February 1st, but gosh, will that even be realistic given where we are with the surge? So anyway, when will we get back to normal, do you think?
Yeah, I'm an optimist, and particularly seeing the level of efficacy of these particular vaccines, I think this is all over in a year. I think if you're looking at the classes coming in next September or October, it's gone.
Mm-hmm. Wow.
I'm a believer, assuming that that there are no huge gaffes in terms of the introduction of this particular product, but we'll see.
That's really optimistic. It's really hopeful too, Mark. I appreciate that. Jeff or Ashley?
I'm sending Mark a Christmas card. I have nothing further to add.
And are you thinking of opening, Ashley or Mark, any alternative sites in case COVID overruns your hospitals? Or what about alternative sites for the vaccine? Is that another possibility?
Yeah, so here in Manchester, we do have an alternate care site available at Southern New Hampshire University. So it's been sitting there since the spring. It's unused and it's just going to hang out there for a bit longer. But we do have that in the plans. I'm hoping we never, ever have to go that route, but it's available.
No, and I would add that if your planning is quality planning, this should unfold fairly smoothly. There's nothing really that is, like nuclear science in terms of this. It's a product that just simply needs to get into people. To you.
Well, I think that I think we're really near the end here, but as I mentioned at the beginning, this is both very sobering and very hopeful at the same time. And I would just say that it's part of our Anselmian values to understand what it means to live responsibly as a member of a community. And, it's right now what it means to live responsibly as a member of a community is to do all of the things to prevent further spread of the pandemic, right? And so wearing the mask, washing your hands, social distancing, all of those things, because those are just things that we do, not just to keep ourselves safe, but also to keep the larger community safe. And for us here at St. Anselm, serving others, being for others, welcoming others, that's at the heart of our mission. So I'd just like to say thank you again to Dr. Mark LaForce for joining us once again. Thank you, Mark, for taking some time. Jeff Sanders, really appreciate you being on the call and providing your perspective as a hospital administrator. And Ashley Conley, thank you for your perspective as being on the front lines and seeing firsthand the challenges to the staff. So again, thank you all. And again, this will be posted on our website. Make sure that you point others to it, those that perhaps could not be with us at this time. So again, thank you for joining and good evening.